Okay, so good afternoon, everyone, and thank you for joining us today for the second workshop for this rulemaking. I am Amelia Boyd, and I'm the program manager for the commission and the organizer for this webinar. This meeting is being recorded and will be made available sometime later this week and posted to the Washington Medical Commission's YouTube channel. The documents which will be discussed here today are available on our website, which is wmc.wa.gov. Attendees, please remain muted unless you are speaking, and if you have a question or comment, please use the raise hand function or the chat. And then just some information to keep in mind for this particular rulemaking. Senate Bill 5184 is now codified as Chapter 18.71D RCW. The bill mandates rulemaking for CAAs, so the WMC must proceed with this rulemaking process. If you seek changes to Chapter 1871D RCW, please contact your legislative representative. And then when providing feedback on the draft language, please keep in mind that the WMC serves as the rulemaking and disciplinary authority for MDs, PAs, physician assistants, and now CAAs. We do not have jurisdiction over other healthcare professions. If you would like changes to WACs governing other professions, please visit the Department of Health's website at doh.wa.gov for contact information. I will begin the roll call of panelists and staff. When I call your name, please introduce yourself. So we will start with Marlon, if you would go ahead.
Good afternoon. My name is Marlon Basco. I'm a policy analyst with the Department of Health, and I support the commission with rules work.
Thank you. Marissa?
Marissa Courtney, licensing manager for the Washington Medical Commission.
Dr. Domino?
Hi, I'm Karen Domino. I'm an anesthesiologist at University of Washington and chair of the Medical Commission.
Thank you. Heather Carter?
Good afternoon, Heather Carter, Assistant Attorney General, and I am the legal advisor to the Commission.
Thank you. Mr. Lopez?
Hi, I'm Ed Lopez. I'm the PA Commissioner.
Micah?
Hi, Micah Matthews. I'm the Deputy Executive Director for the Medical Commission.
And then Dr. Curry, if you would introduce yourself and begin the script, please.
Okay, good afternoon. My name is Diana Curry. I'm one of the medical commissioners. I will be the presiding officer for this rules workshop. Today is Monday, November 4th, 2024. It is 2:42 p.m. This meeting is being held via Teams webinar and in person at the Department of Health located at 111 Israel Road, Southeast Tumwater, Washington. The rule being discussed today is regarding the new profession, Certified Anesthesiologist Assistants. Mr. Matthews, please provide us with additional information regarding this rulemaking.
So Micah, you can go ahead and share if you'd like. Thank you.
Okay, I just want to verify everyone can see this, or maybe I need to go with presentation mode.
So we can see the PowerPoint program.
How about now?
Okay, there you
Better?
go.
All right,
Better.
cool. All right, so there's been some confusion with respect to certain authorities while we've been doing this rulemaking. So I thought it would be helpful to do a little bit of housekeeping to talk about that. So what's been brought up in this is the CMS, what are effectively billing standards. So everyone on the call is aware, it's a public health insurance program, and their standards are defined to participate in the program, to bill, to be reimbursed. And while there are some quality metrics associated with that, those are not the regulatory standards of care. And so just to contrast that with what the Medical Commission does, this is taken directly from our statute and just defines broadly what our regulatory functions are. So there's different types of authorities that the Medical Commission has. So what we're dealing with right now is largely a specific authority or grant of authority by the legislature from Senate Bill 5184. and it allows us to do specific rules on a specific subject. General authority, that's what not most, all of the health professions are granted under the Uniform Disciplinary Act. And, there, for any mandated profession, there's several subjects that you would have mandates on. And so one of those is background checks and permits. There's also mandatory reporting, which is under the Secretary's authority, but we point to that and adopt that. Just a note, with respect to statutory construction interpretation, and Heather, feel free to jump in and correct me anywhere on this, but where there appears to be conflict, the more specific statute will be the one that carries the intent. And then finally, with rule chapter construction, there's certainly specific discretionary and specific mandatory pieces that we always have to put in our rules. And so I've given some examples of that. So the mandatory would be like the military spouse expediting function, the requirement for continuing competency, CMEs on cultural competency, and discretionary would be like the PA license exemption that we put in there. They're both allowable. They're both profession non-specific, but it's the discretion of the commission to put that in. And then there's been some questions about standard of care. So there's a number of ways that it can be determined. So one great example that I always like to reference is the National Comprehensive Cancer Network. That's effectively a network of oncologists who are putting forward their efficaciousness with respect to treatments, and anybody can go to that website, find the specific treatment for the specific cancer, and the supporting information and hopefully peer review research that supports that treatment. The next level is state law, rule, or case law. And so, examples of that, we seem to add something to the Uniform Disciplinary Act every year. The most recent being reproductive fraud, or supplying your own genetic material without telling the person you're doing fertility care treatment that it's yours. So, and then finally, regulatory action. So, due to several Supreme Court cases in the mid 2000s, the standard is clear, cogent, and convincing for the medical commission. You can get into all sorts of oddities with respect to those rulings, how they only talked about a registration for a nursing assistant, and then they talked about a license for a physician, but they didn't reference anything in between. And then finally, the disciplinary orders that the medical commission issue also further define the standard of care. Now, just a note on that, we use outside experts who are not employed by the medical commission. We do contract with them, and they opine on our case and tell us if the standard of care is being met or not. And a lot of that goes back up to rule or case law, and then what the specific national association has worked to define as a standard of care. Sometimes malpractice gets a little bit confused into this, and it is a bit of a gray area, but I like to point out what the typical approach to malpractice is that we don't apply when we're doing standard of care. That's would three members of similar education resources make the same decision in the same situation. And that asterisk is there just to remind me that, again, there's a specific statute in that. It doesn't technically apply to what we're doing with standard of care. With that, I'll turn it over to Amelia.
Thank you, Micah. And then Dr. Curry, you can continue the script.
Okay, thank you. Considering that information, let's begin our discussion on the draft language. Starting on page 3 of the packet, Ms. Boyd, could you outline our focus for today's workshop?
Certainly. Let me get back over to So for our draft language discussion today, we'll start by reviewing and discussing the revisions made based on suggestions from the initial workshop. Then we'll continue from where we left off, which is near the top of page 22 in the packet. So let me share the draft. Here we go. So the first area that we're going to talk about is, I think it's in the definition section. So let me scroll down. So it's going to be this first piece that we had a lot of discussion about. And so we made a change to the definition for commission approved program to say means a commission on accreditation of allied health education programs for CAA HEP. We did some research and this was the result. This change is the result of that. So if we have any questions or conversation about that, now is the time to make any suggestions or if you have any questions. So there's no questions from the audience. Do the commissioners have any comments on this change?
No, seems fine.
Okay, and then next. So in the remaining past the point where we stopped. Oh, sorry, Katerina, did you have a question? If you do, you can re-raise your hand. Okay, let me unmute her. Go ahead, Katerina. Looks like you're self-muted.
There we go. Sorry, thank you.
There.
I just had a quick question, and maybe we can get to this after the qualified physician anesthesiology, but the difference between certified anesthesiology assistant and anesthesiology assistant, maybe just a question for clarification, but we can get to it after you get to number 9.
We can talk about it now, I think, since it's
Oh, sure.
before the next one.
I guess maybe it's just a confusion on my part, but anesthesiology assistant, I believe. I guess what's the difference between the two? Like, why have the two if it's CAA or AA? And I think one of them doesn't reference being licensed, and the other does. I think anesthesiology assistant references being licensed, but CAA does not. So it would seem to make sense that they should either both have licensing under their definition, but it would also seem like in order to become an anesthesiology assistant under this regulatory definition, you would have to be a CAA. So I guess I'm confused about why there's 2 definitions. Just a question for clarification. I might be missing something.
So this is Heather. This is my understanding, and Micah, you can correct me if I'm on this one. So the CAA is the certification is granted by the governing body, the national group that that gives the test. So they provide the certification. The AA is the license that you will get, or you will get an AA license in Washington, but it does require that you be a CAA first to become licensed in Washington, because you have to have completed the education and passed the appropriate exams. It's similar, I try to think of it, it's similar to PAs versus PAC. So PAs have a certification where, so they have PAC. It used to be that you didn't have to have the certification, but now you do. But that's sort of the difference. The certification is from a national body.
Yeah, I think I get that distinction. It's more just when it's when CAA is referenced without AA within the draft, it kind of reads like CAAs can do the things that are prescribed within the WAC, but it doesn't necessarily mean that they're licensed by the state because they're not referenced as anesthesiology assistants.
That's a good point. And if we see that, it should say anesthesiologist assistant rather than CAA. So that's something we can clean up, certainly, if we see it being the wrong term being used. Yeah.
Okay. Yeah, I was just confused. Thank you so much.
Yeah.
Gail, you should be unmuted now. You can go ahead if you'd like to speak.
Okay, can you hear me now?
Yes.
Thank you. I wanted to follow up on Katerina's point because I think the problem with the definition is the very last sentence. It says these individuals may be referred to as a CAA or AA. If you're an AA, you have to have the ticket. You have to be licensed. And so that's why this is confusing. If you just want to define CAA, because you have to be a CAA having had the education and pass the test, I think that's one thing. But just being a CAA without having the license, you can't call yourself an AA. So if you all could take a look at that, that's why Kat mentioned, you know, it doesn't say licensed in part because of that last line. Does that make sense?
So Gail, is your suggestion to delete just delete that last sentence?
Yeah, I guess
Okay.
that would be one way to do it. Because I know the statute says that when you're, you know, looking back at the statute, and this is where I'm going to defer to your AAG, it says no person may practice as an anesthesiologist assistant or represent, and I'm shortening it a little bit, that they are a CAA or an AA without being licensed. So somehow I'm not, yeah. So somehow it needs to sync back to the statute. And if you could just put in, I think it was Kat's initial suggestion that CAA, you know, means a person who's licensed as an A. Anyway, it's just confusing. So if you all could take a look at that and look back at the statute, we'd be grateful.
Sure.
Thanks.
Carolyn Lowe, you should be able to speak now.
Okay, I just want to make sure as we do this, that we make sure that there's no problem if they have CAA on their tag or something when they're in the hospital, that also would mean that they are also a licensed AA. And I guess that's where the clarification maybe just needs to be done so that nobody gets in trouble for saying they're a CAA. So if there's some sort of very clear statement somewhere that for purposes of identifying yourself, that is okay. I just don't want to get anybody get in trouble when they identify themselves.
And I think in the rules, there is a section specific to identification. So I think we're covered there. What I'm going to suggest we do is amend, I guess, both of these definitions of anesthesiologist assistant and certified to make it clear that this would be someone who would be licensed by the commission.
Okay. Any other questions or comments about that? All right, moving along. So later in the draft, we mentioned that qualified physician anesthesiologist was defined, but it wasn't defined in the definitions area. So I added this definition. The note is a revision that was offered. So we need to decide what we want this definition to be. So do you prefer? Go ahead, Micah.
Whatever we do, it does need to reflect what's defined as a physician anesthesiologist that's in this draft, because that's what the statute declares.
So this is what's underlined over here is just what I put in, and then the possible revision is what's on the right in the comment. So I'm not sure which one you prefer. Probably the one in the comment. Heather, did you want to weigh in?
Oh, I was just going to say that that the comment definition is the one that's in the statute itself as the definition for an anesthesiologist.
So we definitely probably want to go with this one then.
Yeah, I think that's probably your best bet.
Thank you. And then Gail, you have a comment? Go ahead.
Yeah, thanks. I just want to affirm that and also wonder if maybe there's not a more elegant way to do it. Might it be possible to say anesthesiologist or qualified physician anesthesiologist means, kind of put them in the same definition? Or in those few places where you have to say qualified, you could just say qualified anesthesiologist because you already have a definition for anesthesiologist. So I just give you those things to think about. Having said that, I think you're heading in the right direction by being sure the definition is consistent with the statutory one.
I personally like the idea of just saying anesthesiologist or physician or qualified physician anesthesiologist defined as up in, I think it's the first definition.
Yeah, just makes it easy. Yeah.
Feels cleaner to me.
Yeah, thank you.
All right, where are you wanting to make a change? The first definition? Like number one? Oh,
I think the first one is anesthesiologist. There.
okay.
So you could just
You
say
want it to say-
anesthesiologist or qualified physician anesthesiologist. And then you can just delete number 9.
Mhm. Okay, and I will renumber later. Okay, so the next one.
We've got a
Yeah.
hand raised.
Go ahead, Amy.
Hey, it worked this time. Thank you. I just, this is maybe nitpicky, but I don't, do you need the word physician before anesthesiologist? Could you just say, sorry, now it's not on my screen anymore, so I can't see exactly what it says, but can't you just say anesthesiologist or qualified anesthesiologist? I don't think you need the word physician in there. I think it's redundant. I mean, because there is no other type of anesthesiologist.
Technically, yes, with respect to licensing. However, I think we're all aware of an attempt at a rebrand nationally. So that's sort of
Okay.
a concern to avoid any potential confusion. And this may be a moot point. It could be that the office-based surgery section that we're supposed to get to today gets determined that it's not something that they would be. It's not a setting they would be operating in. So that's the reason it's here. That's where that term originates. So we're trying to make sure that we're consistent in both definitions.
Okay.
Did you have something to add, Heather?
No, sorry.
Oh, your box just keeps lighting up. So, okay, so where do we need to go next? so need to go to section 120. Sorry, I'm going to scroll a lot. I apologize. Okay, so the next thing that was revised, although I will say this section above for military spouse, I did make some changes to it to make it in line with our recently passed military spouse for the MD and PA chapter. So it matches that one now. That's the only changes I made there. Okay, so exemption from licensure, qualified physician assistant pathway. There was a note to revise 1B. So Micah went and found from their website. So we've made that change. Is there any questions or comments about that one? Doesn't appear to be. Let me find our next one. Is a ways. Okay, our next one is, sorry, we're going to 160. So this is where we said we defined it, but we didn't. So this is one of the things we were talking about where we wanted to keep it consistent. So we've added that definition now. And so I think we've taken care of this one unless anyone has any comments about that. Hold on. There were changes in the retired licensure area. Did we make changes here? Retired license.
Yeah, we did end up deleting something. So there was an add-on in sub 1 that referenced, I believe, what was in 4. And it was exempting what was in 4 and then and then 4 was bringing it back. So we deleted what was at the end of the first clause. So now 4 carries exclusively without any exemptions.
Thank you. Sometimes when you're using track changes and you accidentally accept one, this is what happens.
Oh.
Okay, so I think that one's fine now though, right? That particular section.
It should be, from what I can tell, it agrees. And there's in digging into the 24612 Secretary's WAC, it doesn't appear to conflict anymore.
Okay. Okay. Thank you for that, Kelly. All right, so back to 160. So now we've defined qualified physician anesthesiologist. So I think we have resolved this one. Unless anyone has any changes they want to make there. And then the next one I think is this thing. We mentioned that, nope, we added. Okay, so let's go back up a little. 2 duties which an anesthesiologist may delegate to an anesthesiologist assistant include but are not limited to. So A and B, we didn't make any changes to, but C, we added several things. So this is probably where we need to have some discussion. So if you have any questions about these changes, suggestions, concerns.
Sure. So let me just start off by acknowledging that we've got some comments from folks who were directly involved in this. And I'm also going to acknowledge that they're in conflict. So the WANA's position conflicts with CAA's and the I forget. Sorry, I forgot the acronym of the anesthesiologist. But and then of course the comments that we received from legislators, Chair Riccelli's comments conflict with what Senators Cleveland and Rivers submitted. So what we really need to establish here is how we're going to approach this. And so based off of our legal guidance advice, it's really coming down to what does the statute actually say, and what is is one more specific than the other. What these two items, 1I and 2I, are doing are giving two options of how we could address this if we want to add some attempted clarification. It seems to me, and Heather, you can chime in and explain more eloquently than I can about the specificity and in the first clause and how it's meant to be in the same institution and used that way.
So I think what we were trying to do is harmonize the provisions that talk about the AA can order perioperative pharmaceutical agents to be used within the facility, but then they can't do so, prescribe, order, compound outside of the facility. So we were trying to further clarify those provisions because the word order is in both where it allows it and then prohibits it. So we're trying to harmonize those to show that yes, you can order drugs to be used in the facility under the supervising anesthesiologist supervision or guidance, but that you can't do so for use outside of the facility.
So if the commissioners were going to accept one of the suggestions, I would probably go with 2I simply because it gives a little bit more detail with respect to the in the same facility, but also under the direction of the supervising anesthesiologist.
Oh, go ahead, Dr. Curry. Oh, you are muted.
Sorry.
There you go.
I was going to say that I thought that 2I was much more clear. I had to read everything a few times and didn't realize these were two options, Micah, but definitely 2I made it. I read that and went, oh yeah, that makes sense. Of course, they're ordering everything and administering everything within the institution where they're working. It's not just willy-nilly outside of that. So thank you for that clarification.
Mm-hmm.
And I'm just going to, oh, go ahead, Heather.
I was just going to say, so I was reading some of the chat. So perhaps just to be fully consistent with the statute, you could amend 2i so to say the AA under the, and the word is under the supervising anesthesiologist consultation and direction is permitted to order the items.
That sounds good to me. Sorry, I didn't raise my hand, but it sounds good.
No. Commissioners don't have to raise their hand. You can
I was going to say, yeah, you get full authority to talk whenever you want.
So Amelia, after the word is, you would say under the supervising anesthesiologist consultation and direction. That's from 040C.
So are you talking about this is?
Yeah, after that is, and oh wait, you're right. Sorry, I was wrong. Before is.
Okay.
Depends on what your definition
Under,
of is.
Right.
Is.
Okay, I'm sorry, repeat that.
Under the supervising anesthesiologist's consultation and direction. There you go.
So, and then
And you could
remove
get rid
this
of that.
down
Yeah.
that little bit. Okay, so Ed, go ahead. You don't have to raise your hand.
Oh, hi there. And just a point of clarification for me. Is it true then that the anesthesiology assistant does not have any prescriptive authority of any kind?
Mhm.
Correct.
Thank you.
Right. So part of this is, frankly, a lack of definition of what ordering means. So when we've talked to folks that have been working in these scenarios, ordering is for those purposes calling to the pharmacy and saying send up something. It's not prescribing. It was already part of the treatment and care plan, and it was under the direction of the anesthesiologist and will eventually be signed off in the chart on that. So under that scenario, it's not prescribing. It's simply facilitating the process of doing the surgery or the procedure. And Dr. Domino, if you want to provide further clarification from my inartful comments, go for it.
Oh, well, I like having both of these statements there because I think it makes it very clear about what they're allowed to do. And so we give an order, right? And then someone carries it out like a nurse does. We don't have to sign it. What we want to have is them to be able to do that we already co-sign the anesthetic record, but getting these kind of things would be ridiculous. They should be able, this is within their job description. What isn't within their job description is prescribing medications outside of the operating room area or the perioperative area, such as for pain medication for people to go home with.
So looking at the only change is that the note about 4 should be actually 3. That's okay. So it looks like we might have a correction in 1I. And I guess my other question in the group is, should we reverse these and put 2I first and then have 1I come second as sort of the cleanup clause?
That might make more sense logically.
Hold on, sorry. Trying to find out. So we're supposed to be referring to 3 in
Not 4.
I.
Okay.
I just wanted to
Drafter's
clear
error.
that up
My bad.
first. No, I changed the numbers because we removed something.
Oh,
So,
all right. Well,
okay, so we want to move this to up here. And we want to make it little bitty I. Make this I. And then change this to 3. Okay, so I want to go back in the comments a little bit. So Kelly, I don't know if you can speak or not, but do these changes support what you are asking for in the comments?
I guess I'm against whatever Kelly, sorry, I don't know who all these folks are, who they represent or anything, but say if it's someone giving a break and because they may be giving breaks in one room and then they have to, go into the Pyxis and get out a medication, which they are able to do to give to that patient. And then they leave that patient after 45 minutes or whatever time people are having their little breaks. And then they go to a different room. So they may have more than one patient that they're taking care of during a course of a day. And it just seems unusually weird recommendations to say that they can only prescribe to one patient. Did I catch that comment right that I read in the chat? Sorry, there are a million chat things and I can't see them all.
Go ahead, Carolyn.
Yeah, Dr. Domino, I represent the Washington Academy of Anesthesiologist Assistants. Yeah, I was looking at this one and it seems to me that when you're just dealing with the anesthesiologist directions, it would be for that patient where it needs to be done. To say it can only be done one at a time, and if they have two of these that need to be done the way it's working, even though they're only caring for one single patient, it just seems like that's not necessary. Per the directions of the anesthesiologist is where that comes in. Does that make sense?
Yeah, I guess it makes sense. But I'm not sure we need to say that, do we? I mean,
No, I don't think you need to
yeah.
say it.
I mean, someone suggested saying one patient intraoperatively.
Yeah, that was Kelly, and she does have her hand raised, so you can go ahead, Kelly.
Thank you. This is Kelly Camp, and I'm the president of the Washington Association of Nurse Anesthetists. And my concern is just where you have multiple different areas within a facility. I don't know if they'll have CAAs helping in, say, a pre-op or a post-op clinic that may require some different prescribing needs to make sure that we are clear that those things are happening in the intraoperative area. And a CAA is not going to be caring for more than one patient at one time. No CAA is going to do that. And so it doesn't need to be one patient per day, but you're not going to be obtaining and administrating meds to more than one patient at a concurrent time. So I just want to make sure that it is clear that the CAA is getting medications under the direction in the perioperative area so that there's no confusion for ordering medications outside of that area.
Well, that potentially could include pre-op area perhaps as well, right? So I don't know, I don't like the idea of, I mean, to me, this is how we work. We don't, and it allows flexibility. If you have another patient they're going to have who needs something like we're not even allowed to give any IV fluids now because of this IV fluid shortage in the preoperative area, that I really feel that having this thing of one patient at a time is not appropriate. It's under the direction of the anesthesiologist, and leave it to the anesthesiologist to help specify that.
And I think, Dr. Domino, there's a couple of other considerations too. Hospital or institutional risk profiles are certainly going to come into play with what they're going to allow as far as practice ratios and that sort of thing. The statute also, and now the rule, is also talking about in the same institution. So you're covering everything with a more broader statement of what could be happening there. And I will just call out a blast from the past. Teresa Schimmel's coming in here, former commissioner, PA commissioner. Welcome. Haven't seen you in a while.
Hi, Teresa.
Ugh. She said hi, everyone.
So given I don't want to say conflict's a strong word, but given the difference of opinion that I'm seeing in the chat, what I would recommend is just let's stick with what the statute is saying. That's going to provide the flexibility. It does actually cover everything, but it's also, to everyone's point, there's different settings and there could be different needs, and we should probably be drafting this from the standpoint of enabling practice as opposed to trying to restrict it.
Thank you for your
Thanks.
advice, Micah.
Yeah. So are we making any changes to these two as a result of the comments that we've been discussing? that's a question for you, commissioners.
I agree with how it is. I think if you start to say intraoperative, perioperative, and only one patient at a time, it actually becomes more confusing. And as Micah said, potentially restrictive. So I would favor a broader, the way it's written now.
I'd like
I
to
like the
echo.
way it's written.
This is Heather. I think there's a couple of missing words, but when it says under direction or consultation and direction is permitted in order to order the items specified in, but not, oh, never mind. I was reading that wrong. I think there just needs a comma.
After N.
Yeah.
And then after 2.
Correct. Or after C.
Okay. Okay. All right. So are we moving on from this piece then? Are there any other comments or questions?
There's a clarifying comment in the chat, but it seems to support what you just did.
Okay. All right, so we moved this, we didn't delete it, so. Are there any other comments about this section? If not, we're going to move on to a different section. Sorry, I'm working from 2 documents here. So we did make a little change here. There was some like not subtitles, but subheadings that was pulling out certain sections of this particular subsection. And so what I did instead is we created a new section, and then to talk about, I can't even remember what, but we're going to get to it. And then I just put signing authority instead of having it as a subheading, because the rule folks don't let us do that now. I know it is in some of our other rules, but that's something that's being phased out. So that way you can quickly get to the signing authority piece.
You know,
So-
Amelia, just before that, it says something about may not order any medications. I mean, this one, it's like an anesthesiology assistant may not prescribe. But it says order.
Right.
Didn't we
Dr.
use the
Domino.
word order?
Right. So again, this comes down to the specific authority, the specific drafting versus generalized drafting. This is sort of a blanket prohibition, but above, you've got something that specifically allows them to do that within the institution.
Okay.
And do we
you.
need to say this here, Micah?
It is confusing.
It reads, I definitely got confused when I read it. I went back and read the other paragraphs and thought that there was a conflict. So I just.
Yeah. So this whole section is copied directly from statute with the exception of the little I and 1 little I and 2 little I that you just accepted. So this is
Got it.
verbatim.
And we can't say something like that last sentence, say something like outside of the institution or outside of the direction of the anesthesiologist, supervising anesthesiologist.
I'm going to defer to Heather on that one, and there's a hand up as well.
Yeah, I think, I mean, they can't prescribe even in the facility or do some, compound or any of those things. So my advice would be to leave it as is. That's why we were adding those things above. We'll try to clarify the difference between the two. But I understand it is that same term was used in 2 different ways in the legislation. So it is somewhat confusing.
And then Amy, if you want to go ahead.
Thank you. This is Amy Brackenberry for the Washington State Society of Anesthesiologists. So would it make it more clear if you added the word independently in that last sentence? So it said an anesthesiologist assistant may not independently prescribe, order, compound, or dispense drugs or medications or devices of any kind. I mean, I know they can't
Commissioners.
prescribe at all, but does that make it even more clear that they can't do this independently? Because as we've stated up above, they can order only under the direction of the anesthesiologist. So if you add the word independently, you're making it clear they're not doing this independently.
Go ahead.
So I
Ed.
think, adding that would, then that applies to prescribe, compound.
Yeah.
and so I would not, but maybe you could add another sentence or something to say, except as authorized above or in section, whatever.
Okay. Yeah, that's maybe better. Yeah.
That might be good, Heather, if we can do that.
Yeah, I like that, Heather. Thank you.
I would agree as well. Thank you.
Section. Sorry. Right?
It was great.
Okay. Go ahead, Kelly.
I had a question more for Micah, just after that presentation at the beginning of this workshop, where you talked about where the statute seems to be in conflict and that the most clear language would be what goes with. And it seems like we have fairly clear language here in number 3, and now we're adding multiple other sections to try and make a different section more clear, but then it's changing this section that is completely clear. So I'm confused how that works.
I didn't say what was more clear. I said what was more specific. So the section in 2 is specifically granting authorization to be able to order with the direction of the supervising anesthesiologist, so long as it is within the same institution. This section 3 is a blanket. So the way we interpret that is the more specific section carries. And everything else after that is try to clarify what it's saying.
Maybe you could further clarify and say, except as, and just, so it just refers to ordering in section 2. So you're not then saying, making it sound like you can still prescribe and compound and all of those things. Except ordering as authorized in section 2.
Except ordering. Except order?
Or, yeah, I don't know how.
I just,
Um,
are we actually, I don't think that the anesthesia assistants are actually ordering though. Aren't they using, say, the order sets or something that's been signed off by the supervising anesthesiologist, and they're, deciding to administer drugs that are from that list, for example, but they aren't actually ordering it themselves, are they? I thought we were saying they weren't.
I think that's the issue, though, is that the word order is used in authorize. They are authorized under the supervisor's consultation and directions to order perioperative pharmaceutical agents, medications, fluids. But the word order isn't defined. And so I think it's used in a different way, possibly, as it's not prescribing. So I don't know if you want to add that or not. I mean, it's up to you. I don't know if it helps. It might make it more confusing.
As a reader, I have to say that the word ordering seems to make the matter more confusing, because if the professional is unable to prescribe, it appears that ordering may be interpreted as prescribing. However, I
So
will
take
say,
order. Yeah.
I will follow that by saying, if you qualify it by saying as authorized in section 2 of the as subsection 2, then maybe that qualifies it better. So,
And that section does specifically clarify that ordering is not prescribing.
Yeah, I think I would take out ordering here and just leave it the way it was.
Yeah, I would too. I also have another question, and that is, what is compounding? Does that mean that if you have say it's often with antibiotics, the pharmacy doesn't make up the antibiotics necessarily. It gives you a vial, and then you have to make it up and shake it up yourself. Is that compounding?
I think we'll need to look that definition up. I know that it is defined in law and rule, I believe.
Yeah.
What
Someone says mixing.
Yeah.
If you could look
So
it
I
up,
think-
because they
I
at
think-
work they use the word compounding for it.
So it has to be, I think, with the Legend Drug Act, it talks about it has to be 2 or more ingredients that you're mixing.
But you mix the antibiotic with a saline solution as an example.
Yeah, I think really when we're seeing compounding in the statute, what they're talking about is more leaning towards sterile compounding, where you have a set of requirements such as proper venting, a hood,
I
PPE,
see.
that sort of thing. So it's much more involved, and the Pharmacy Commission obviously has tons of definitions and regs on this. And again, what we're getting here is there, and this is I got this from Kyle, who used to work as an attorney for the Pharmacy Commission. There's not really a proper definition of order in the law, and so that's the ambiguity that we're having to deal with here, because it's we're interpreting it as it's already part of an anesthesia care plan. It may have already been prescribed, and this is just calling down and asking for it when ordering it to come up. And Ms. Schimmels has got her hand raised.
Go ahead.
Hi. Yeah, I noticed that Shane had already said this too, but mixing an antibiotic that comes like dry, or you're diluting it or something in your IV fluid or in a push, that's completely different. Compounding would be more if you're mixing a medication with something that's not normally given. So in dermatology, we frequently will mix 2 medications together that are not normally prescribed together. So I would look at it that way rather than adding like an antibiotic or diluting something out so that you can give it as a push or something like that.
So Teresa, does that mean if you're, say, doing a block and you're adding epinephrine to the block, to the local anesthetic, is that to me doesn't even seem like compounding.
No, that's because
Yeah.
that's standard of care. So that would
Yeah.
not be the same thing. This
Yeah.
would be something that is oftentimes not considered to be either within the standard of care or to be something that you're adding. It's hard because of anesthesiology is so different than dermatology, but dermatology is like adding adding CeraVe cream to your cortisone cream and mixing both of those together. That's compounding.
Thanks for the clarification.
Yeah, I hope I didn't make it thicker.
And we can look at more at the pharmacy laws, but there is a difference also between compounding and reconstituting something. So it may be that some of that is reconstitution.
That's a much better word, Heather.
Sarah Brown was, you did have your hand raised. I just didn't get to you before it went back down. They provided an example in the chat, but I've unmuted you if you'd like to just tell us. Maybe not. Okay, I will just read it. They say, if I needed to order blood products for my patient intraoperatively, I would need ordering privileges to place these orders from the blood bank within the EMR. If I needed to wait for the anesthesiologist to place these orders within the EMR, this could unnecessarily interfere with workflow and patient care.
I think if you need to order blood products emergently during a case, that you need the anesthesiologist to be aware. So even if it was a phone call and they're in the other room and they'll get there in 2 minutes and they say to you, go ahead and place the blood bank orders for type and cross, that's under their direction.
But a
But
lot of
I-
times the discussion occurs at the beginning of the case when you have these cases. They should be able to administer blood and order it. I mean, because it's a lot of it's ordered preoperatively and sign those forms.
So
does
are we
this edit-
good with, yeah.
Yeah. So does this edit cover the concerns? As far as the commissioner?
Does it have to be specified? I mean, it's not under this thing about order. Isn't the other part, didn't we have solutions or something? In the section was earlier regarding what could be ordered under the direction of the anesthesiologist?
Do I need to go back up to the 2?
Wait, say that again, Karen. What were you asking?
Back up in the earlier section of section 2, where we authorize things, did we authorize, was blood listed there?
No, but it shouldn't need to be if it's part of the plan of care for the patient. I mean, for example, in OB, blood products are often, you check off massive transfusion protocol or whatever, so that it's pre-checked essentially. And that's part, like you were saying, that's part of the plan of care. My comment was that if it's not been discussed and it was a case that was expected to have, 20 mils of EBL, and now suddenly you need blood, I don't feel comfortable having the anesthesia assistant make the decision to order the blood. I'd rather have that quick phone call to their supervising physician who is supposed to be immediately available.
Well, that's the consultation
right
part of it,
so
but the ordering, if you're busy and you're in a lot of spaces, you may not get to the computer or run.
You don't have to, but that's the whole point. But the phone call has to happen. The consultation has to happen. That my patient's bleeding out, they just nicked an artery. Can I order blood? Yes. That's all you need, right? That's under the direction with consultation, whatever, that's covered. But the comment in the chat was like,
isn't blood an agent? Yeah.
Blood products are specifically called out in a different section. So blood products and fluids, they can obtain and administer them perioperatively.
So we should add blood products there.
It's in a separate provision further down.
I see. Okay, thank you.
Yep, it's covered.
Yep. It's in the S, I believe, of this. There we go.
I mean, this is all under the anesthesiologist's direction. There are always those who might abuse the system, but really, this is discussed up front in cases. And if it's an emergency, a massive transfusion protocol, then you immediately do get called generally and drop other things. So I didn't want to restrict their hands in providing good care.
Okay. So are we fine with this edit then for 3? Thumbs up from the commissioners or?
Yes,
Okay.
looks good.
And then the change that we made to sub 4 is that we added in just this little descriptor that it's about signing authority. And then we pulled out the supervision ratios and group supervision and made it its own section, which is next. So are there any questions or comments about sub 4? Go ahead, Gail.
Sorry, I didn't have a comment about 4, just the one that follows it, so I will wait.
Okay. All right, so we did pull out the supervision ratios and group supervision, and it is in its own section now. There was a lot of conversation around this one the last time. So, all right, what are your comments? You can go ahead now, Gail.
Okay, thanks so much. Sorry about that. Hey, first, just one trivia thing. I noticed the word physician anesthesiologist, and when I did a word search just for the word anesthesiologist, just quickly in the rules, I noticed sometimes anesthesiologist is used and sometimes physician anesthesiologist is used. So I'm just giving you a heads up about that. My comment about this has to do with structure, not any of the words essentially and what they say. I don't think one little I or one C, one little I fits well where it's located. And so just an idea to consider from a drafting perspective is perhaps to create a couple of different subsections. And a number 2 might be in the first paragraph before in the exception request, the physician anesthesiologist must provide, and then you have all that. And then you could do a subsection 3, and I would just start that with exception requests may, at the sole discretion of the commission, be denied. I think that's more clear, just to kind of break it out that way. Just because I don't think C one little I is, it doesn't logically follow C, so.
Do you think it should be a 2 then?
Yeah, or I'd make it a 3. I mean, just you all can think about it. Sometimes it's just style about how do you make it the most clear. And so it could either be a 2 or it could be a 3, and you could break out in that first paragraph just before A, you could make it a 2 in the exemption request. That the physician must provide, because that's kind of, you kind of have a book of business there. Here's what you need to tell us. And oh, by the way, we can say no if we want to. So, we have the discretion. So just something to consider.
I'm fine going with whatever makes it more clear.
Yeah, I mean, I like that because, when we do 2, A, I, and it does get a little muddy. So I think that's fine. It does make it easier to read for sure. Do the commissioners have any angst about making that change?
No, I like the suggestion. It makes it easier
Looks good
to understand and read.
All right, any other questions or comments about? So at the first workshop, there was a request to add in due process, and that's what this new 3 is about. And Heather, did you have any comments about that piece?
No, we just put that in. A brief adjudicative process is just basically a paper appeal. So it's just done through written means, nothing, no full hearing or anything like that. And this will make it much faster and easier to do.
And cheaper.
True.
So does anyone have any issues with this change? I mean, we added 2 and then we changed the structure a little bit and then we've added this 3. Do the commissioners have any issues with new sub 3? Nope. Okay.
Looks fine.
All right, so this is where we stopped. Obviously, this needs a new number. This would be 4 now. So this is where we stopped the last time. So now I'm just leaving this up to you on what direction we need to go. If there's any questions about new sub 4, and as we move through the rest of the language. Comments, suggestions?
So far, it makes sense in my mind.
And I'm glad we pulled it out into a new
I
section.
thought it was
and we could just
fine.
point to
Yeah.
it. Thank you. Okay. Moving on to the next section. So this section is pulled from the PA. So PAs have this in their rule as well, this practice limitations due to disciplinary action. Does anybody have any comments or questions about this section?
My only thought on this is it very much makes it sound like the anesthesia assistant has one supervising anesthesiologist when I think the reality is it's more going to be group practices, I would think. So I wasn't sure if there was some way to kind of soften this to account for that. I mean, is it going to be common that there's just going to be a one-to-one between a single physician who may have their license restricted for whatever reason and their anesthesiology assistant?
Because the AA can have
Well,
several supervising physicians, right?
Right. Yeah.
true, technically, but here's where this is 1871D030 sub 1. Unless approved by the commission, an anesthesiologist may not concurrently supervise more than 4 specific individual anesthesiologist assistants at one time. And so I think that does get to it to some degree. We do speak in the previous sections to a group model, and that's meeting the requirements of that same section, but sub 2, which talks about alternates and that sort of thing. So I mean, I think we can certainly do a redraft if we think that'll work, but the law implies without additional requests that there's going to be up to 4 individual anesthesiologist assistants being supervised.
Couldn't we just add a sentence at the end of 1 that says this applies to all supervising physicians involved, or?
So, Micah, just to be clear, if you have a group of anesthesiologists supervising a group of anesthesia assistants, so say it's you have, right, you have 4 or 6 or 8 anesthesia assistants and 3 or 4 docs supervising, one of those docs gets dinged, right? But actually the other 2 or 3 docs are still supervising that same group, right?
Mm-hmm.
Obviously not all at one time. You're not going to have 1 to 8, but you'll have 1 to 4 or 1 to 3 or whatever it ends up being on a particular day. So it just, when I read this, I got a little bit lost in the idea of, I don't see where this scenario of the one, anyway, yeah.
I mean,
I
there's
understand the
nothing-
intent of it
Yeah.
completely, of course,
And,
but
and there's nothing that say that you have to keep it. So I think that the consideration that I would make here is, with PAs, you've got the practice agreements, and now come January 1, you'll have collaboration agreements as well. So there is an implication that there is more distance in supervision, and therefore there'd be more concern about the one-to-one issue. So, I mean, with respect to CAAs, the law is pretty clear, as well as the information we've gotten, that there's going to be, direct, almost line of sight for most of the time. So this may not apply, but we want to make sure that it was in front of you to consider. So if you want to strike it, that's entirely your prerogative.
Got it. I guess at the very end where it says, unless otherwise authorized in writing by the commission, that was the part that kind of got me like, what? Wait, no, we don't want to hear about all this. I would say something like, unless there are no other supervising physicians available with unlimited scope of practice, or I don't know how you would say that, but that was the part where I was like, I felt like that was a little bit heavy-handed, that last little bit.
Yeah,
Sure.
I have a little concern as well, just under practicality. So let's say you have 30 ORs, okay, and you have 20, some anesthesiologists, and you have your whole number of, other providers, including AAs. How does that mean that everyone running the schedule, even at night when you may be running 10 rooms in the evening, that you need to know whether someone has had some sort of limitation of their scope of practice? Because I mean, you certainly would know if their anesthesia practice is limited because they couldn't work. I just don't know how. I mean, I don't know.
I'd like to comment that I think while the intention is a good one, logistically, this just doesn't work or transfer over like the PA process or the or the PA supervisory role. It just doesn't translate similarly. Like you mentioned, Micah, many PAs work in separate locations from their collaborating or supervising physician, as opposed to this profession basically under the same roof.
Sure.
And to somehow, and I guess I would echo the term heavy-handed. I mean, I understand the concept and the idea, and I understand the reason for it, but I don't know that, I think this needs to be reworked from a wording standpoint to make it practical. I can just imagine the response by a hospital administrator or a department chair. They would read that and they go, wait a minute, we can't stop everything because Dr. Smith, has been placed on hold for something, an investigation. We just can't do that. We can't do it. So that's why I'm saying something different. The rewording needs to happen with the same intention. I get that.
Mm-hmm. I think I would probably suggest just cutting the section at this point, based off of the feedback of the three commissioners at this.
That sounds good to me.
Yeah, I think if somebody gets their license restricted to not prescribe, say, outpatient opioids or something, that's not an uncommon thing. That doesn't even apply in this situation. If you have an anesthesiologist working in the OR area or peri-op area, they're going to have their license enough to do that. The hospital administrators will make sure so that anybody they're supervising should be fine within that scope, within the peri-op area. So I think we could strike it safely without jeopardizing any patient safety issues.
Okay, thank you.
And does that include sub 2?
That's the entire section.
The entire one. Okay.
You may want to leave 2. That's telling the,
I know.
the
Yeah,
AA
that's a
that they
different
need to tell their
matter.
supervisor if they're being investigated an action. I would think you'd want to leave that.
I agree.
And then
I would
change the
wholeheartedly agree.
heading.
Yeah, I'll change the title of it.
Just notification of regulatory action. No, it's not regulatory action.
Disciplinary action.
Well, there's no
Right?
discipline yet with an investigation, and there's no regulatory action with an
Oh, I see.
investigation.
We'll just say investigation or disciplinary action. Right?
That makes sense.
That's what that's what it's talking about.
Yeah, that's what it's saying. Maybe come up with something more eloquent, but okay. So for reference, I'm sorry, we're moving on from that one, right? We're done with that one? Okay. For reference, this section, safe and effective analgesia and anesthesia, is, I believe, a direct copy of our WAC for MDs that is on this same exact subject. So we may need to talk about this one a lot. I'm going to pull it up just in case we need to reference it. It will let me. Ugh, it's not letting me. We need to go back to it. Okay. So I think there was some concern about including the dental part, right?
Yeah, the intent was to exclude that as a scope, but the way that the rules are drafted are a little bit iffy.
I want to say it's
And there's a comment from Kelly. Are we in 246-921-300 now?
yes.
Okay. Over. Yeah, I think we can certainly do a cleanup on that, Kelly. There's not an intent to allow them to perform surgeries.
So I think what we need to do is probably rewrite this section where it's more geared towards AAs, CAAs, right?
Mhm.
Is that what I'm hearing? So we may have to bring this one back. So our fix was removing, I think this is, I don't remember what number this is. 3. Was adding D to 3, this new D, and then removing everything else below the old D, old E. That was our fix to this.
Very clean.
Seems pretty direct.
Okay, let me. So Micah, I need to make a note on this one, right, to change it.
Change what?
To change this where it doesn't talk about surgeries and procedures, right?
Yeah, we changed. We got to pick a word that's not perform.
Yeah. Okay. You go back to the beginning. Sorry for the scrolling. Okay. Scrolling again. Just fair warning. Okay, so we like new D and removal of the rest of it, right?
I guess I would answer that by asking, what more do you need to add? Or I guess another way to say it is, what is unclear?
Hopefully nothing.
It just seems pretty clear to me.
Okay. Oops. All right, and then So we like this, moving.
To address
we need to read-
Shane's comments
go ahead.
in the chat, no, so there's no intent to let them work in a dental practice. So currently how that works and the reason these rules exist is there are physician anesthesiologists and in some cases dentist physician duly licensed individuals who go around and they are doing anesthesia for dental procedures and dental offices. That's a separate section of WAC that we did not port over on purpose, just because it was not deemed that CAAs would probably be working in those scenarios, and in the more complex scenarios for dental, that happens in a hospital anyway. So they might be involved in those scenarios. This section specifically exempts the dental aspect as we just saw, and I think there's an open question at this point about CAAs performing or being involved in procedures in an office-based setting, but these would be the rules that would govern that.
Yeah, I'm in support of not having them work in a single dental office because of all the issues there as well. There are a lot of safety issues. I'm happy to include the section on office-based surgery that could potentially be some sedations, like in GI offices or other type of offices. So,
And to be clear,
if there's an
this
anesthesiologist there.
Yeah, so this section specifically does not address procedures that occur in hospitals licensed under RCW 70, as well as, I'm going to get the acronym wrong, ASF, ambulatory surgery facilities, I believe is what they're licensed as. So the beginning of this chapter specifically exempts those two things. This is only talking about anesthesia applied in an office-based setting, and obviously our intent is to make sure that there is a physician anesthesiologist who they are working with directly.
So do we need this number 5? Because this is about physicians.
Yeah. Is this the section that talks about where you can't be the person performing the procedure and giving the anesthesia? You have to have somebody else doing
Well, this
that.
is about
Or maybe it's further down. I don't know. It got a little confusing. I was like, wait, who
further
are we
down.
talking about now? Yeah. Okay.
Now,
So
I
this-
fully acknowledge that this one's a confusing rule.
So this accreditation and certification is just about the facility, right? So it's not the
Right.
responsibility of the AA or the CAA to make sure it's accredited or certified, right? That's the physician's job.
Right.
So I feel like we can strike this.
Sure.
And it's tough to leave C in here. I don't think we need to deal with that either. So again, it's not their
Yeah,
responsibility.
I thought all this was confusing. I didn't know why we were.
Well, hopefully it's not confusing in our other rule because it's a direct copy, but okay, delete that. So I think we
This
could
was the
strike six
paragraph.
as well.
Yeah.
Yeah.
Yeah. This is the one I was talking about. I couldn't figure out why
Mhm.
this was in here to do with what this had to do with anesthesia assistants.
And it's a direct copy from the MD rule.
Yeah.
So I think we can strike it, can't we, Micah?
I think so. This is for when a physician's doing the sedation and the procedure.
Are we good with striking it then? Yes.
So the only question I have comes is, say if it's a pain physician, I don't know. What I don't want them to do is to actually then supervise anesthesiology assistants providing sedation in their pain facility. I mean, they supervise RNs to do that generally. I don't think they'd ever do that because the cost is, they're more. But anyway, so I'm happy to get rid of that, but do you ever see this being used in a pain treatment facility?
I mean,
I
technically
was
that
actually,
would be
yeah.
office-based surgery. I'm
Yeah.
looking at 6 though, what I'm looking at is, operative procedure and intravenous sedation, and I'm not sure that that happens in pain clinics.
Oh, well, they may give midazolam and fentanyl and monitor somebody while they're doing a block.
Hmm.
They may use propofol, God forbid, but I don't know,
But this is pertaining to when there's no anesthesia assistant or anesthesiologist available, which,
Yeah.
I mean, they're all anesthesiologists, right, in pain clinics. Well, no, they might be
Yeah,
PRNR,
a
but
lot of them are, but
yeah.
I don't think I
Yeah,
don't think they'd have AAs practicing in that setting.
Yeah.
Because they
and
can hire an
again,
RN and do that,
Yeah,
right, under their
yeah.
direction.
Yeah.
So I think it's fine, I think, to get rid of it.
Yeah, as I read it, it means both the physician and the AA are both gone. They're not there.
Hmm.
Yep.
So I don't see the reason to keep it there.
So
Now
Amelia,
we
if
have
you
to
could
deal with
scroll up
7, sorry.
just one little bit. And so yeah, for 7, I think we need to delete the word may include. All of those things need to be included.
So do you add should include, are to be include, must include,
I mean, I would just say
or just
delete may.
include?
Yeah, just includes. I mean, you can say shall, but
Okay, shall include. Okay.
but at this point, there's not the way I read it, it's not an option.
It needs to be an and, right? Because all 3 things have to be there.
Good call.
Shall in here. All right, so are there any questions or comments about this change to this, what will be a new sub number? I'm not sure what it is right now, but this 7.
You got rid of the conscious sedation thing, right? They provide anesthesia care.
Right. So I think we're talking about part C, and that's the question that I have here. I don't believe that a CAA is going to be credentialed in a hospital for again, whether it's conscious sedation or we're calling it monitored anesthesia care. It seems like the physician anesthesiologist would be credentialed, and perhaps the physician performing the procedure.
But I don't know. Don't they credential providers? I mean, I think, don't they credential nurses? So they would be probably credentialed.
I would ask, why wouldn't they not be credentialed?
That was a gap in my knowledge. I don't know how far down the credentialing process goes as far as scope. So that was a question that we had for Wisha. It looks like Katerina saying she's waiting for feedback, and so as soon as she gets it, she'll send it back to us.
Okay. So this is a hold and wait then?
Looks like it. credentialed nurses, physician assistant. And then I guess on the conscious sedation piece, that's probably left over from when these rules were originally written. Sounds like there's an ask to change it to, what was it? Monitored anesthesia care or something like that.
I mean, it
Yeah.
should be anesthesia services because there's a whole spectrum between that and general anesthesia and other type of things, regional anesthesia that they may be doing in that office. So I don't, yeah, I would get rid of conscious sedation. So you could say
And just say
credentialed for
anesthesia
providing
services?
anesthesia services.
Okay.
That instead of what's there?
Well, the
Anesthesia
second one
privileges,
is,
I don't know what they're called. I mean, but there's
yeah,
not just conscious sedation. It's not just
Yeah.
monitored anesthesia care. It could be general anesthesia. It could be regional as well, right?
yeah. I think,
It
Amelia, I
won't
would
be
probably,
general because you have to be general anesthesia. It has to be an ambulatory surgery facility.
Oh,
So
I
it
see.
will be at ASF.
Yeah,
So
we're
this is
we're
only
still in the
for
office.
like the lower, yeah, we're still just in somebody's office.
Yeah. So I think the term conscious sedation, isn't that an older, like everyone, we all had to get separately credentialed to supervise the RN pushing midazolam or whatever, while you were doing a procedure. It feels like that's a bit of an older term though. I
It
don't know,
is.
is
It's
it still
called
used,
moderate
Karen?
sedation.
Yeah,
Yeah,
yeah.
but
I,
I don't know why would you have an anesthesia assistant provide moderate sedation? It would be ridiculous when an RN could do it and that. So they
yeah.
have to work under direction of an anesthesiologist. So it seems that offices may wish to provide some more intense kind of anesthetic care.
Right, but the GI doc or GYN or whoever can be credentialed to do that
Yeah,
and supervise the RN. I mean, that's part of
yeah,
the,
but in this, so if it is say a GI office, they often, if you're going to have an anesthesia provider, they're probably not giving a little midazolam and fentanyl. They're providing probably propofol, which is different.
right.
so I'm going to come back to the question of, so a GI office, having gone through this, generally is some form of license as a ambulatory surgery facility or something like that. So I come back to, is this necessary? Because it seems that the comments I'm hearing and reading are, it's not practical for a CAA to be involved in an office-based anesthesia thing when you've got a nurse or something else.
If the law is that when they do provide some deeper level of anesthesia sedation, then is an ambulatory surgery center, then I mean, they're office-based care, but if our state requires these as being called an ambulatory surgery center, I'm not sure how relevant an office setting is, because what are the offices?
Are we sure that that's true? I feel like there are small GI practices and things where they're not an ambulatory surgery center. They're not an ASC. They're just a office that does a lot of procedures and uses intravenous.
We could do some research on that. I know
Yeah.
Marlon's
Yeah, if you
Marlon's on here,
could, because
and
Yeah.
yeah.
so we've got two
I mean, it might
so
be a plastic surgeons, but the plastic surgeon, that's an
They,
ambulatory surgery center. I
yeah,
mean,
they
I think it's
they usually,
mostly in GI and dental, isn't it?
that's where they do
yeah,
all
so
the colonoscopies, and
right. So we've got two
outpatient.
comments. One is from Shane Angus saying that CAAs are involved with office-based care. And from Kelly Camp, those small practices cannot generally afford to employ a physician anesthesiologist. So we'll ask, I'm going to ask Marlon to help us do some research on the gastro GI clinics licensed where they're doing those procedures, and we'll put a note on that to get feedback. And we're also waiting on feedback for the credentialing aspect. Sure. Let's see. And there's a note from Robert Sung. Usually anesthesia are not involved in conscious sedation because there's such a large demand. However, because CAA works under an anesthesiologist, anesthesia services are requested. Agree that most RNs provide that once credentialed. And some examples are women's health, derms, vascular, and podiatry. And to Carolyn's point, yeah, I think I understand what you're saying. And generally the model that we've seen is not an employed anesthesiologist, but a contracted one. So they come in on specific days and do cases that day and then go to the next clinic.
Okay. So we have some work to do on this section, obviously. Because of that, and because it is 421, do we want to, I mean, obviously we're going to have another workshop. Let me see how much is left. Misconduct, abuse. Yeah, so the only thing left after this is sexual misconduct and abuse, and then the fees, but we can't do any work on the fees. So, and sexual misconduct and abuse sections are direct from statute. So, I think we can wrap up this work on the draft here, and we can go through as many comments as we can before 4:30. Because we're going to have another, I mean, we have 3 other workshops scheduled, so we will definitely be doing that. Okay, let's see. Let me get okay, so just to briefly go over this proposed rule development timeline, we will do that in a moment. So let me pull up the comments. Gotta get the packet open. Okay, so some of these comments we saw, the first 3 comments in the ones from our website, we did see at the last workshop, the first workshop, but we didn't talk about any of the comments really. So I see that so Sarah Brown is here, and Kelly is here, and Amy is here. So I would ask the 3 of you, I know Sarah Brown can't raise her hand or anything, but for Amy and Kelly, have your comments been addressed so far in these 2 workshops? Either one of you can go first. You're
This
both
is Amy.
unmuted. So
Yes.
go ahead.
Yeah. So from the WSSA perspective, we're generally in support of what has been proposed. With our goal being we want the rules to adhere as closely as possible to what's in the statute.
And then Kelly.
Yeah, we would like things to adhere both to the statute and to the agreements and negotiations that occurred on the House side. And I know that there is conflicting information from Representative Riccelli and from Senator Cleveland. And I believe that is because the negotiations occurred on the House side, they did not occur on the Senate side. So the information from Senator Cleveland is true as far as what happened on that side. So we are just wanting to make sure that everything holds true to the agreements that were made. Thank you.
So with that being said, do we want to jump to this letter from Senator Cleveland and Senator Rivers? Are we okay with that? So this was added to the packet late on Friday. I'm not sure if all the commissioners have had a chance to read it, but I will give you a moment. It's in the packet, so I probably need to make this a little bigger. It is very tiny. Does anybody have any comments about this letter? Clarifying information?
No, I don't, but there was a comment saying, it's 4:27 now and it's sort of hard to see and maybe people want to think about it. I mean,
Sure.
I certainly didn't look at it.
Yeah, I didn't see it
Yeah.
either, Amelia. I'm just reading it now and I feel like I
Yeah,
need some
and
time to digest this. I saw Mr. Riccelli's comment, but I think I looked at the packet like a week ago, so maybe, or whatever, a few days ago. Not sure I saw this.
Yeah, and I've been away the bulk of the last 2 weeks, so I got in late.
So we do have several other workshops scheduled. We have 3 scheduled for the remainder of the year. So we have this one today, which has been very productive. Thank you for everyone attending. We have another one scheduled on November 18th, and then another one scheduled on December 6th, and then the final one scheduled on December 16th. So we will bring forward all the comments we've received since we didn't really get to discuss them. And we will work on the things that we've talked about today, and we will have a new draft ready before that November 18th meeting. So I'm hoping by next Wednesday-ish, we'll have a packet out for that meeting. So yeah, and then as long as we finish the rule within these 3 workshops, or perhaps before and not need another workshop, then our proposed timeline will still look like this. We will request to initiate the next step in the rules process at the January 10th business meeting. And then we still hope to have our hearing for this rule May of 2025, and then adopt it August-ish. And then late next year, the rules will be in effect. And so, yeah, then that's our next step, is to have that workshop on November 18th.
Great, thank you.
Do you need me to read the closing script, Amelia, or are we done?
Yes, please go ahead.
Oh, okay. Thank you for your discussion and comments. Any written comments not covered today will be carried forward to the next workshop for discussion. If there's any questions that have not been answered, maybe that's the time to do it. Next steps were just discussed by Ms. Boyd. Our next workshop's the 18th, I think it is. And therefore, if nobody has anything else, no other hands raised, then I will close the workshop and look forward to continuing our discussion of these rules soon. Thank you.
Thank you, everyone.
Thanks, Amelia. Bye.